Hello, my name is Jean-Philippe Collet. I'm from Paris, and I would like to welcome you on this 2019 PCR Congress, and we are going to talk today about stroke prevention in TAVI. So it's my pleasure to welcome Alexandra Lansky from Yale. And so Alexandra, tell us about the rate of periprocedural stroke and who should we protect and how?
So periprocedural stroke rates have been relatively constant, as we've been looking at this in high-risk patients, intermediate-risk patients, even low-risk patients, I would say. So and even first-generation, second-generation devices. So it's been in the range of 3 to 4%, and has been relatively constant. We really haven't seen much of a change in terms of the stroke rates with increased volume, so experience with the, doing the procedures, or, advancements in the procedures. And I think really what it has to do with is what we know from TCD trials and data, that it's really with the manipulation of the valve across the TAVI valve across the native valve, and all the manipulation, the positioning, the inflation, we're seeing the embolization of debris to the brain. So I think the reason why we're seeing such constant rates, it's really sort of inherent in the underlying disease. The other point that's really important in terms of the incidence is we know based on imaging, when we do systematic imaging in all patients, we actually see silent injury to the brain in the vast majority. So 99% of patients have evidence of injury.
So it's mainly mechanical. And,
right.
And do we have tools, or do you think that imaging may help to identify patients who are at higher risk than the other one?
Yeah, I think what's been very difficult, very frustrating, is the fact that it's so unpredictable. So we see the vast majority of patients have MRI evidence of injury. 4% have clinical stroke, and trying to predict which one of those patients is going to go on to have a stroke is very difficult. So we've identified some risk factors, but not enough to be able to pinpoint a certain patient being high risk, and that's sort of the big challenge, I think, in the field, trying to identify which patients we should target for prevention, protection, etc.
And so how do we prevent? Is it rather device-related,
yeah.
drug-related?
Yeah. So key point is that about 50% of the strokes are actually periprocedural, so really happen within a day or two of the procedure, so procedure-related. And of course, there's ongoing risk. We know that is more patient-related, atrial fibrillation, etc. I mean, there's a whole host of different risk factors. The prevention is, of course, this whole development on cerebral embolic protection that really serves to protect the patient during the procedure specifically, will not take care of the strokes after that. So I think it's dual. It's really cerebral embolic protection, and then pharmacology after that, depending on the stroke risk of the patient.
And so do we have strong evidence for mechanical protection devices in terms of symptomatic stroke versus non-protection?
Right. So there's growing evidence, that's what I can tell you. I mean, there are two main devices. One is FDA approved, that's the Claret device. It's a basket, it's a dual basket device that's placed through the arm with a 6 French catheter, and essentially captures debris. It covers 2 of the 3 cerebral vessels. The other device is the TriGUARD device, which is a completely different concept. It's a deflector, so it's placed through the femoral, through a 9 French sheath, across the aortic arch, covers all 3 cerebral vessels, and the idea there is that it deflects debris downstream. So no capture, just deflection. I think the differences between the devices are, the SENTINAL device is, at least for now, really protects 2 out of 3 vessels. The Trigon protects all 3 vessels, and again, the concept of capture versus deflection. So the SENTINAL device is approved in the United States. That was based on a relatively small clinical study, certainly not a neurologic endpoint trial. But what it did show was, first of all, that it was safe. So no safety concerns there, but it captures debris basically in every single patient. So it got approved and passed through the FDA on that basis. The Trigon device is still actually finished the IDE trial, and that is being analyzed at the moment. So hopefully we'll be hearing more about that shortly. But what we have seen, single center series, propensity matched analyses, etc. At 72 hours, we're seeing significant, 60, 70% reduction.
And this is symptomatic stroke, right? Not
yes.
MRI stroke
symptomatic
evidence.
Stroke,
symptomatic
yes.
stroke.
Yeah.
So do you think that the following statement that we should protect, all our patients who are undergoing the TAVI procedure is fine?
Well, I think it's an ongoing debate. The main issue is we can't predict stroke. And, it's a spectrum, right? So some patients are symptomatic, some are not symptomatic. But the question is, should we be preventing debris from going to the brain? There is evidence that debris, even if asymptomatic up front, right, which is what determines whether you have a so-called stroke, there is evidence that there is downstream or, down the road, cognitive decline. So from my perspective, if you ask me, my opinion is yes, you should be protecting all patients, because we know that if we can prevent that from going to the brain, there's going to be, potentially longer cognition, etc. And of course, what we're hoping is for stroke prevention. I should mention in the SENTINAL trial, which led to the approval of the Claret device, there was a 40% reduction in stroke. It wasn't significant, but nonetheless, certainly a strong signal for improvement.
And do we have long-term follow-up of these patients in terms of cognitive function, or?
Yeah, we would love to. Unfortunately, that's one of the pieces of evidence that's lacking. So most of the studies are going up to 30 days, 90 days, but not beyond that. So I think we need funding. We need the longer-term studies. We definitely need the stroke studies, so definitive. Hard endpoint of stroke, and those are all coming. We're in the planning phase, several people in the planning phase for those types of studies.
And do you think that the periprocedural anticoagulation treatment is a key player, or it does not matter?
I don't think so. Well, so currently, as you know, heparin is the standard during the procedure. We know from Bravo that bivalirudin is an alternative, but that hasn't been shown in any way to have any impact on stroke. It never has been evaluated for that purpose. But I'm not sure it really would make a difference, because, again, the mechanism here is particulate embolization. It's the calcification, it's the atherosclerotic, debris that's released from the valve that is causing this. So I'm not really convinced, at least in the procedural time frame, that this is sort of a thrombotic issue.
So the take-home message is we should take care of the brain.
We have to take care of the brain. We're very good at taking care of the heart and the coronaries as cardiologists. We focus on that. But as cardiovascular specialists, I think it's time for us to really think about the brain, and I think this whole field has opened up that door for us. And I do think that's the case.
This will our take-home message.
Yes,
Thank you very much,
Thank you.
Alexandra.
Thank you.